response sets. So when we get in contact with an antigen, no matter if it's foreign or if it's self-antigen, the T lymphocytes will have receptors that can contact this antigen and respond according to what it considers to be normal or abnormal. So the T cells, if you remember, they form in the bone marrow. And once they form in the bone marrow, they have to exit the bone marrow, go to the thymus, and mature there, where they have some hormones like thymosin, thymopoietin that help them to be mature, to become mature. But the B cells, which stays within the B cells, they mature in there, and then they exit from the bone marrow fully mature. Now, in the thymus, if you have self-reactive T cells, you're supposed to clonally delete them because you shouldn't attack your own cells. And I explained to you before about these autoimmune diseases. And then they have genes, these T cells, that can rearrange, and they can produce many different types of T cells. And these type of T cells have a T cell receptor that binds to a specific antigen, and only to that type of antigen. Now, the part of the antigen that the T cell receptors binds to, it is the antigenic determinant, or the epitope. So then, if it's something then that it requires the attention of the T cells, like if it's a foreign antigen, then the T cells undergo mitosis and they form a clone. And then once they get fully trained, these cells will help us to become immunocompetent. Now, again, anything that responds to self-antigens will be clonally deleted, so self-reactive T cells will be deleted to allow self-tolerance. So, it's like looking in the mirror. You look in the mirror, and then you start combing yourself or brushing your teeth, whatever you do to improve your beauty, or whatever is the reason you want to see in the mirror. You don't look at the mirror and start slapping yourself, right? You develop self-tolerance. You might have done a mistake, you might have hurt someone, but you don't start beating yourself in the mirror. You develop self-tolerance. So similarly, our T cells, they're supposed to be able, yes, to recognize our own antigens, but do not attack them. But they're supposed to be able then to become reactive against something that is wrong. And then this is the process. So from the bone marrow, they exit the sinusoids in the bone marrow, they reach the thymus, and then over there, destruction of the cell-reactive T cells happens, while the ones that are mature now can go into the bloodstream to populate lymph nodes and lymphatic tissue, like the tonsils, Peyer's patches, anywhere where we have lymphoid tissue, mucosa-associated lymphoid tissue. So only mature T cells will reach these organs. Now, in our cells, we have these molecules that are called MHC, which stands for Major Histocompatibility Complex. And these MHCs are unique to each of us. So they are determined genetically, and then these MACs can help to present antigens, and they can be subdivided into two classes. We have class 1 MHC and class 2 MHCs. So these MHCs, as I told you, they are unique to each of us, but we have similarities between some MHCs that can be explored to see if someone is compatible to receive an organ or to give an organ to someone. The two individuals in the world that has most similarities between the MAC are identical twins. Out of that, not even can be said from non-identical twin siblings or your parents. It can be, if you're going to receive an organ or donate an organ, it can be someone that is nothing related to you. But you have MACs that are similar enough to allow the compatibility. Now, these MACs are found in every nucleated cell, but not in the red blood cells. And they will serve as a docking place to keep these antigens. So, for class 1 MHCs, is found in all nucleated cells, and they interact with cytotoxic T cells, or CD8+. MHC2, it is found only in antigen-presenting cells, which includes macrophages, B cells, and dendritic cells. And MHC interact with the T helper cells. MHC2. So MHC1 which are these cytotoxic T cells. MHC2 interacts with the helper T cells. So there you see the name for them, and they have to be naive. That means that they haven't encountered an antigen before. So cytotoxic is TC, and helper is TH. So endogenous antigens, how they are presented. Well, when you have a self-antigen and it is broken down by enzymes in this cytosol, only the piece, the antigenic determinant, that it is important for setting the immune response will be presented. And you have this antigenic determinant transported through the rough ER. And then in there, you put them in the class 1 MHC or MHC1, and then you put them after in the plasma membrane. So this is the process. So the cell will synthesize a self-antigen or a foreign antigen. So here, the messenger RNA, it is translated into a protein, so that makes the antigen. And then the antigen is going to be broken down by enzymes in the cytosol, giving some pieces or fragments, and then the antigenic determinant, the fragment that is going to be immunogenic or that is going to set an immune response, is going to enter into this rough ER, is going to migrate through the rough ER, and now is going to put in a vesicle that has MHC1. And then that vesicle is going to fuse into the plasma membrane, and you will display this antigen in this MHC. Now for exogenous antigens. So in this case, you have to have endocytosis because it is found outside of the cells, these antigens. And then once you endocytose this antigen, you would put them in a vesicle that is called phagocytic vesicle, and then you will fuse it with a lysosome. The lysosome is going to have an enzyme, and you will have a phagolysosome. And then you break down this antigen in fragments, and then you will have the lysosome fusing with a vesicle from the raw VR that contains MHC2. And then after this, you will have the presentation of this MHC2 with the antigens in the plasma membrane. So now, in this case, will be a pathogen, any microorganism. You put it in this phagocytic vesicle, you fuse it with a lysosome that has these enzymes, you break down this pathogen, and then you extract these antigen fragments from the pathogen, and then you will have already pre-made MHC2 from the raw VR that is going to exit in a vesicle, and then this vesicle, you will fuse it with these antigens that are found in this vesicle, and then you will migrate this vesicle toward the plasma membrane, and then you put it in there. So the point for both, whether it's endogenous antigens or exogenous antigens, is that you have to have them in an MHC. Why? Because your receptors from CD4 or CD8 will have interactions with these MHCs, and then they will start becoming active. So then the next part is going to be activation of the T cells, clonal selection, and differentiation. So let's say that you have a dendritic cell that ingests these antigens, and then these dendritic cells, since are antigen-presenting cells, will present these antigens in the MHC. And these antigens, when they are presented in the MHC, they will form what it says here, MHC antigen complex. And then depending on the MHC, whether if it's 1 or 2, is whether you attract a specific lymphocyte. If it's 2, it's going to be CD4, a helper. If it's 1, it's going to be a cytotoxic, or CD8+. After this, you have recognition and binding of the T cell receptor into this MHC antigen complex, and you form a sandwich. So in here you have your APC. Let's say that the marker is the antigen. So this is MHC. If this was MHC1, then CD8 is going to bind the cytotoxic. It's going to have affinity for this. And then the antigen, the marker, is going to be in between the lymphocyte and the dendritic cell. Now, if it's an MHC2, like this is the dendritic cell or macrophage, if this is the MHC2, then what is going to come is going to be a CD4 helper T cell. And then you will have, again, a sandwiching of the antigen between the receptor of the antigen-presenting cell and the receptor of the lymphocyte, no matter if it's a helper or if it's a cytotoxic. And then after that, you trigger a clonal expansion and clonal selection. So here we have what happens then. Endocytosis of antigens, processing of the antigens and presenting the antigens in these MHCs. So this is MHC1, so this antigen is presented by MHC1 receptor from this dendritic cell, so CD8, cytotoxic T cell come and bind. But if it's a MHC2 and with an antigen, then you have this helper T cell binding into there. And this can be like a viral antigen. Any questions? Now, something about these helper T cells, and then these T cells, is that when they bind to these receptors, the MHCs, they will co-stimulate. And that co-stimulation is physical, but also chemical, because you have co-receptors that bind physically, but also you release cytokines that allow the expansion or the clonal expansion of these helper T cells or cytotoxic T cells, and as well induces the maturation of these T cells into memory T cells, so that the next time that you encounter the same antigen, you will produce the same response. That's the point. You don't want to start over again. So every time that you have memory is to speed up the reaction. So then memory, no matter if it's T or B, is basically called immunological memory. So here is the process then. You have MHCs and receptors for T helper or T cells interacting with these antigens in these MHCs with this dendritic cell. And then you have clonal expansion of these lymphocytes. And then you form effector T cells and effector helper cells. Effectors means that they are ready to react. And then you leave some memory cells there for future cases. I told you before, like if you were walking on the street and then you get in contact with a burglar and that steals something from you. Next time that you see it in the street, you know what to do. You're not going to say, here's my money, or here's my thing, my belongings. No, you will develop memory. Okay, so that's what is the purpose of this. So then MHC2 presents exogenous antigens that come from bacteria or viral particles. MHC1 present endogenous antigens. So why do you think we need both MHCs? Why we not only have one type? And which one will be the best to keep, MHC1 or MHC2?
Probably MHC1.
So it's not that you want to keep one or the other. You need two, but why do you need two MHCs? Why waste the time of having two MHCs?
Wouldn't one be for identity, to like recognize what it is, and the other one would be to get rid of it?
Yes. So,
Is it because of the variation of antigens that there are?
as well. So we have both of them because it helps us to have identity in our cells so that you don't present antigens all the time when they are not needed. And actually, all the nucleated cells, with the exception of the red blood cells, have MHCs. And that helps for the lymphocytes to be able to recognize what it is your own without an antigen and get enhanced to attack when there is an antigen there. And specifically for MHC, and you can see it in here, it serves two purposes. It activates the cytotoxic T cells, which are the ones that attack the cells with intracellular bacteria and viruses, but also tags them to destroy them. Because you already have something that is wrong internally. So then that's one of the purposes. Now, when it comes to helper T cells not only helps to make more cytotoxic T cells, but also helps to make clones of lymphocytes B, which, as you know, when they are activated, they become plasma cells and they secrete antibodies so that you can neutralize as many antigens as possible from binding into cells, preventing infections. Like, what if the antigens are bound into a bacteria? Well, you don't want all the phagocytes or all the cells that are around to be able to bind these antigens and then endocytose them, because you will infect more cells. So you are blocking with these antibodies, these antigens, so that it will be easier to recognize by the macrophages and destroy, and also by other phagocytes, like neutrophils, basophils, eosinophils, so that they can set an immune response. So that's when the lymphatic system, the innate and the adaptive immunity interact. It's better. They can be a strong person trying to fight you, but if you have a bunch of friends, they will block it. And then you will go there like a cytotoxic and eat the person, right? Like what they say, we are not machos, but we are muchos. So, or we're not machos, but we are muchas. So that's the point. Okay, so you have to work with both of them, innate and then adaptive. So then the T cells, what they do is they secrete hormones like interleukin-2, which activate the T cells and stimulate the proliferation of the T cells. And then when it comes to the macrophages, they get stimulated because the T cells, the helper cells, release IL-3, interleukin-3. So then the macrophages will come and phagocytose any bacteria or any dead cells. And then T cells, helper cells, what they do is they bind directly to B cells. And then once B cells get activated, they form a clone just like the cytotoxic T cells into effector T cells, which in this case will be plasma cells secreting antibodies, and into memory B cells. So here it is how T helper cells, which are, remember, the CD4 plus, how they work. So here you have an antigen-presenting cell, this macrophage. This macrophage presents an antigen to this T helper cell, and then you have co-receptors that physically interact. That's a physical interaction. And then this one can secrete IL-3 so that you can form more macrophages And then you will have a feedback between the macrophages and the T helper cells, in which the macrophages, they produce interleukin 12 to stimulate the proliferation of these T helper cells so that you can have a greater response. It's like a cascade. And then once this interleukin is bound as well by these macrophages, they become more active. So they endocytose more antigens or bacteria. So then this interaction, this co-stimulation between macrophages and helper T cells lead to proliferation of the B cells, and then that can lead to the production of antibodies by the plasma cells, and then you form these memory cells. And then this as well stimulate the production of T cells with this interleukin 2, cytotoxic T cells. So helper T cells makes the B cells to make antibody, make clones of T cells, makes the macrophages to become more active, and then form more clones of T cells, T helper cells. And we have a finite number of these lymphocytes. So that explains why when someone has HIV, which destroys these T helper cells, these helper T cells do not come back to the normal levels. And depending on how this infection progresses, it can progress up to the AIDS stage. You can have like 200 lymphocytes per microliter of blood or so, which is very low. So you cannot fight infections really easily, and then you can have opportunistic infections. Okay, so that's how immunosuppression happens, because those helper T cells have receptors for HIV. And then when it comes to cytotoxic T cells, the function is just kill cells. That's why they're called cytotoxic. They're activated when they bind to its target cell, and they kill the cells by releasing perforins, which forms pores in the plasma membrane, just as the complement when it forms the membrane attack complex. What cells do attack? Well, cancer cells, foreign cells, and cells infected with intracellular bacteria or viruses. Now, that's cytotoxic, and again, interacts with MHC1. Now, one way that these cells can also kill other cells is by inducing programmed cell death, which is apoptosis. And then the T cells can seek and kill another target cells after that. So here we have an activated T cell binding to this MHC1 with the antigen. And then this cytotoxic T cell has vesicles with perforins, and then into this cell, it gives these perforins that are going to, in some cases, induce programmed cell death. And then the cell will be degraded. And once it does its job of killing this cell, it detaches from this cell and goes to the next and kills the next. Now let's talk about grafts. So grafts can be classified into different types depending on the tissue of origin for receiving that transplant. So if you are your same donor, that will be an autograft because it's your same tissue. If you receive an organ from your identical twin, that will be an isograft. It's very rare because most of us, we don't have a twin. And I guess for some of us, thankfully, we don't have too much And then allograft will be from someone who has similar MHCs, but will be a non-identical twin, and it has to be the same species. And xenografts, which I think they're taking a resurgence, it's between two individuals of different species, like pig organs, for instance. Out of the rejection possibilities, the one that hit the highest will be the xenografts, sooner or later. But the one that keeps the lowest will be the isograft, and of course the autograft. I mean, now anything can happen with transplants or with organs. You can have a tissue that apparently is compatible with yours, right? But again, if it's from someone who is not, if it's not an autograft, and if they don't rinse the organ, if it's a bloody organ, like corneas, they don't require to have this type of classification because they are immunoprivileged. So we don't have any surveillance for the corneas. So those ones can be transplanted without so much problem. But when it comes to a bloody organ, if you don't rinse it really well from the donor's lymphocytes, these lymphocytes can attack your own body. They can make a clone. And then you would have something that's called graft versus host disease. And it can happen. I mean, people go happy to their home with their new organ, and months or years later, they have signs and symptoms of rejection. And what happens? Well, you have lymphocytes from the other person in your body that is attacking your own body. And then even to the best of the tissue, like autograft, isograft, allograft, xenograft, if it's not preserved well, the tissue, or if during the surgery, I don't think that happens very frequently, but if the surgeon, it is not careful enough when handling the tissue, it can damage cells in the tissue. And guess what? When you become competent, because they have to immunosuppress you to receive a transplant, you will start rejecting that organ. And it's sad because imagine it takes years for some people to receive certain organs, and then you get it, and then the surgeon ruins it. So, okay? So then rejection happens because you have T cells that can damage the cells of the organ if the organ has a problem, and this cause necrosis, which is cell death due to injury. And then these MHCs come from a set of genes that we have in chromosome number 7 that is called HLA, human leukocyte antigen. And then your HLAs are screened to see if you have a match. And then again, in order to receive an organ, you have to have immunosuppression. Then examples of transplant, we have hematopoietic stem cell transplant, or HSCT. So this is known as bone marrow transplant. When it can be given? Well, when someone has diseases like leukemia, because you have stem cells that are constantly multiplying without a reason, and they overcrowd the other normal cells, and you have anemias, etc. Lymphoma, which is a tumor of lymphatic tissue, or if your bone marrow fails. Okay. As we age, we can have problems of production of red blood cells, like we can have aplasia of the bone marrow, so in this case you need a bone marrow transplant. So that's cell-mediated immunity details. Any questions? Okay, now for antibody-mediated immunity, which is also known as humoral, it's much simpler than cytotoxic. So similarly as the cell-mediated, you have receptors in your B cells that attaches antigens, and then they undergo clonal expansion, and then you form memory B cells. But the production of antibodies, which is the ultimate goal of this immunity, is given when you have a clone of B cells that recognizes a specific antigens, and then you start producing your antibodies, which takes a while to form. I mean, sometimes can be, if you don't have immunological memory before, it can be between 7 to 15 days. And then in the second phase, once you have memory, you have greater levels of antibodies because you already have the memory for that specific antigen. So the proper name for antibodies is known as immunoglobulins or gamma globulins. And then we have 5 classes. We will see which they are. But again, they are produced by plasma cells. So then here is how the B cells mature. So you have bone marrow. So your cells of the lymphoid line divides with mitosis. They give you these B mature cells in the bone marrow with self-reactive B cells that are destroyed whenever they encounter antigens. And then the mature ones, they go into the bloodstream, and then they can populate the germinal centers in the lymphatic nodules in the lymph nodes and other tissues like the Peyer's patches, etc., malt. So then on this area where the B cells are located, they combine antigens, and then they become sensitized. So the sensitized then B cells will start processing these antigens that they encounter, and then they present it on class II MHCs. So they also have class II MHCs because they are nucleated cells. And then B cells now can interact with T helper cells, and they co-stimulate, as we saw before, with co-receptors and cytokines. And then that leads to expansion not only of the helper cells, but also of the B cells. And the B cells divide repeatedly, and then they form the plasma cells, and then the memory B cells. So here is how this process happens. So you have here these B cells. And these B cells start binding these antigens, and they will be located here in the lymph nodes once they populate the lymph nodes. So here you have your MHCs, and then you have free antigens that binds to these antibodies, and then you will have part of these antigens processed and presented to these T helper cells in the MHCs. And then this T helper cell has a co-receptor that binds to this MHC, and then start releasing cytokines so that you can expand the B cells by mitotic divisions. So then through these mitotic divisions, you form memory B cells, plasma cells, and these plasma cells, they undergo a change in which, if you remember, B lymphocytes or T lymphocytes have a large nucleus and very little cytoplasm. But now the nucleus is going to become smaller, the cytoplasm is going to become larger. Why? Because you increase the rough endoplasmic reticulum to start producing antibodies. And then with these antibodies, which is a blocker for antigens, you can block antigens from bacteria or viruses. Now, serology examines the structure and functions of antibodies and then helps to quantify the levels of antibodies, which is also known as anti-serum. We have the basic structure of antibodies, which is like a Y shape with this part that is going to be attached to two arms. And then it is made of two polypeptides that has, four polypeptides that has two heavy chains and two light chains. And this part of the Y will be the constant region, while this other part, the arms, will be the variable regions. And then at the tip of the variable region, we have the antigen binding site, which is the hypervariable region. That is very specific for specific antigens. So here we have the polypeptides. So two heavy chains, two light chains. This is the constant region, and this is the variable region. And here we have the hypervariable region or antigen binding site. And these chains are held by peptide bonds with amino acids that has sulfur on it. And then here we have, within this heavy chain in the constant region, complement binding site that binds proteins from the complement system. So we have 5 classes of antibodies, and some of them, they can be found in single units like this, but some of them they can be found in dimers or pentamers. Units of 2, so these 2 are bound like from this part in here. So these form a dimer. Some of them, they form pentamers. So we will see which form pentamers and which ones form dimers. So IgA is actually usually a dimer. This one, it is secreted in the skin, mucous membranes, and tears, saliva, sweat, breast milk, and semen. IgA. IgM, it forms pentamers, and this one, because it's a pentamer, it can bind up to 10 antigens, like here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is IgM, this is IgA. How many antigens can IgA bind as a dimer? Do it with your fingers. How many? Up to how many can bind? Not what is the minimum. The minimum can be 1. Well, this is IgA, this is IgM. IgM can bind up to 10, but this one is IgA. How many IgA can bind? 4. 1, 2, 3, 4. Can bind up to 4. So IgM can also exist as a single subunit embedded into the B cell and in the plasma membrane as the B cell receptor. So we saw it here before. IgE, it is one of the less, so in order of abundance, first is IgG, IgA, IgM, IgD, and IgE and IgD. So this one, IgE, it is important to interact with antigens associated with parasites, and also it is important in allergic reactions. So this IgE can bind to mast cells. I'm pretty sure that there's a picture there. So it can bind to mast cells, which are granulocytes, and these mast cells have histamine, serotonin, and other chemical mediators of inflammation. So if this is a mast cell, or if it's an eosinophil, so you have granules, right? And let's say just only is histamine. So this IgE, it binds here into the surface of these basophils or these eosinophils or mast cells. And when this IgE is cross-bridged by an antigen, like let's say this is an antigen, that triggers degranulation. So you have release of histamine. That's what it leads to. That's what it leads to the allergic reaction signs and symptoms, which is coughing, sneezing, runny nose, etc. So that's known as degranulation. Now, IgD, no one knows so much its function, but it seems like it's important for the activation of B cells. And then, did I skip IgG?
Stop producing antigens? That's how you deactivate them?
Actually, I don't know, but it seems like it makes it to be easily to react in the immune system. But I don't know the answer for that. I skipped IgG. So IgG is actually the most abundant type of antibodies. Is between 75 to 80% of the antibodies that we have in serum. It's a monomer, so it doesn't form dimers or pentamers. And this is the only antibody that can cross the placenta. So this one will be the ones that can attack the baby's blood if a female is Rh negative and the baby has blood that is Rh positive. And IgG, it is the type of antibody that actually, here is a mnemonic for the classes of antibodies gained. So now this IgG, it is increased highly when someone gets exposed to an antigen for a second time, the same type of antigen. While when you get exposed for an antigen for the first time, you generate higher levels of IgM, but you start forming IgG, but at lower levels. And then second time that you encounter the same antigen, you increase the levels of IgG, but you still produce a little bit of IgM. The first time that you encounter an antigen, this is called primary exposure. The second time that you encounter this antibody will be secondary exposure. So then, whenever they do titers, whenever they're checking titers of specific antibodies, let's say that someone is trying to see if you have titers for hepatitis B virus. They're measuring to see if you have IgG. If you have IgG against hepatitis B, it can mean two things. Hepatitis B virus, it can mean two things. Either you have the infection or you were vaccinated against the infection. They give you a shot. I mean, usually when you work in the healthcare field, you have to be given shots for hepatitis B virus. So they give you the shot, they vaccinate you, and then you're supposed to get your second shot, and then you get it. To see if this second shot worked, the booster, you have to measure your IgGs. If you don't have IgGs, that means that there was something wrong with the vaccine because you didn't produce IgG. You didn't produce memory. So IgG tells you that you have memory against something. And then something important about the antibodies is that within the circumstances, I mean, if it's the first time, it takes like a week or 15 days if it's too delayed to form the antibodies. But once you have memory, you form them within 3 days, 72 hours. But what it causes that? Well, you have a genetic rearrangement in the constant region of the antibodies that lets you to form antibodies much quicker. So all you need to do is change the variable region according to the antigen that you are in contact with. And then the function of the secreted antibodies is agglutination and precipitation. Agglutination is clumping. So these pentamers of IgM, which will be actually the ones that are secreted when someone has a mismatched blood reaction, they can clump the antigens and the erythrocytes. That's what you saw in those cards for reading the blood type. Those clumps means that there's a bunch of IgMs binding all these antigens. And then these complexes can precipitate, they can fall into a solution, in this case in the body, and they can clog arteries. So then that's the function of this. Others opsonize. So if you have a bacteria and you bind these antibodies to coat this bacteria, the macrophages are more likely to go and ingest it. You opsonize. Remember what we saw with the C3b as well, part of the complement. And I told you, it's like a cake. They can bake you a cake and they can give it to you and it tastes pretty good. But what if they apply frosting and then they decorate it? You're more likely to eat it. So similarly, antibodies or C3b from the complement opsonizes these antigens in bacteria or these bacteria to be much easily destroyed. And then they can neutralize the antigens, preventing binding of pathogens into your cells. And they activate the complement system, like IgG and IgM bind to complement. And they stimulate inflammation like IgE. When it degranulates, releases histamine. Histamine opens up the blood vessels. You have inflammation. So that's a summary of the antibody classes. I already told you about primary immune response. So it's effective, but it lasts like 4 to 5 days. Peak levels of the antibodies in primary response between 7 to 14 days. And then memory B cells will live for years to an entire lifetime. It depends. Sometimes adults, they need to be vaccinated. And that's when you can measure the titers of the memory antibodies, the IgG. And then secondary response, it takes 1 to 3 days. Peak levels of the antibodies, 3 to 5 days. The antibody levels will be 100 to 1,000, the normal. Main antibody in secondary response will be IgG. In primary response, primary has an M, IgM, but you have both. So here is the view of this primary response on the left, secondary response on the right. So lag phase refers how long will it take you to form the antibodies. Shorter for secondary, longer for primary. And then you start here with IgM, and then it takes over IgG. Secondary response will be greater for IgG, lower for IgM. For vaccination, we have attenuated vaccines, live, and then we have vaccines coming from dead organisms or from fragments of these organisms. No matter what it is, you are trying to stimulate the memory so that whenever you encounter these pathogens, you don't get sick. So the ones that are fragments of vaccines are called subunit vaccines. Some of them can be coming from toxins that are inactivated, in which you call it toxoids, like tetanus toxoid, or the diphtheria toxoid, the one that causes whooping cough. And then inactivated vaccines will be coming from killed pathogens. Of course, if it's an immunocompromised patient, what do you think? Would you give an attenuated or kind of half a live organism into their body? Would you give a vaccine that has almost killed microorganism? Yes or no? If it's an immunocompromised patient. Not all at once.
Wouldn't it put them at risk?
Yes, so would you give it? No. So which ones can you use in them? Kill pathogens or subunit. Okay, but you don't give attenuated. So for polio, we have attenuated, and then we have killed poliovirus. The killed poliovirus is Salk. That's the one that gives you in shots. It's given here in the United States, I think Canada too. But other areas of the world, they use Savin, which is drops of attenuated virus. And those are more effective than the killed. With the killed, you have to have boosters. But of course, you cannot give attenuated organisms to someone who's immunocompromised. And then with this COVID-19 pandemic that we had the fortune to develop a messenger RNA vaccine against COVID-19. Was developed in a very short period of time, and it turns out to be effective. I think I want to skip to allergies. So that's a lot of cancer and microbiology. Let's see, where are we?
So, Professor, so you were talking about for older people. So, for vaccine, a booster wouldn't be effective for older people. They necessarily need to have the actual vaccine.
You don't restart necessarily, but it's like almost. I don't know specifically in which they can give all the set, or if it's only one booster.
Like for hepatitis B.
Any other questions or comments? Okay, now for allergies or hypersensitivity reactions. So a hypersensitivity disorder or reaction is when your immune system overreacts. Hypersensitivity disorder is the fancy word for allergies. And we have 4 major classifications for this. Now, the opposite of a hypersensitivity disorder will be an immunodeficiency disorder, in which one or more components of the immune system fails and the person will be more likely to have infections. Now, an autoimmune disorder is when your body attacks its own cells. And then for hypersensitivity reaction, we have an acronym, that can help you to learn the types. It's called acid. So the first one, type 1, and it's written with these Roman numerals, it is anaphylactic reaction. So allergies or hypersensitivity. So it's type 1, type 2, type 3, and type 4. So it will be acid. Anaphylactic. Will be cytotoxic, immune mediated, and delayed. This one can be subclassified as local or systemic. And this one is immune complex mediated. So that's your acronym. So we will see how each of these happens. So, type 1, which is local type 1, affects around 20% of our population, and people know it commonly as allergies. But no matter if it's type 1, type 4, type 3, type 2, it's an allergy, hypersensitivity reaction. So your body's responding more than usual. So this happens when you get in contact with an allergen or an antigen. And this antigen binds to your mast cells, then binds into these IgEs that were cross-bridged, and then you have the granulation reaction. So your histamine from your mast cells or your eosinophils, your basophils, is released into the bloodstream, and then you open up the capillaries of the area where you get in contact with these allergens, and you start having the sneezing, the coughing, teary eyes, and runny nose. What allergens commonly affect people? Pollen, dust, mites, dander, peanuts, shellfish, and bee venom. Some of these allergies basically, well, they start, of course, by binding these antigens to the B cells, and then you have memory. But some of these will be so serious that leads to a lot of the granulation of these, or the granulation of a lot of these mast cells, or these basophils, or these eosinophils, that can open up so many capillaries, and then you have extravasation or exiting of fluid from the circulatory system into the interstitium, that the person will have a serious reaction. And the person can die within minutes because you have massive release of histamine. As soon as you have symptoms, no matter if it's local, and that's called systemic, so you can have something that's called anaphylactic shock. As soon as you have symptoms of runny nose, coughing, and sneezing, when you get in contact with these antigens or these allergens, that means that you were in contact before because you have memory. So someone who already had these signs and symptoms of having low blood pressure because they get in contact with these allergens, and they also have closing of the airways because they have edema in the respiratory system due to these allergens, the release of this histamine and heparin. The person knows how it feels. I mean, it feels so bad feeling the sensation of lacking air. So the person knows and carries EpiPen and know what to avoid because they have to find out what was the cause. So then in this case, you have IgE for type 1. So another name for local is type 1, for type 1 is immediate because the reaction happens really fast. Okay? And then subsequent exposures again lead you to more inflammation, and depending on how bad it is how you'll have the signs and symptoms. So then this is the first exposure. You have your allergen binding to the IgE in your B cells, and then you form antibodies through these plasma cells, and then you bind these antibodies to these mast cells. Next time, cross-breaching to neighboring IgEs lead to the granulation, release of histamine, and other chemical mediators of inflammation and signs and symptoms. Another example will be a skin rash, which we know as urticaria or hives. Asthma, it is part of these type 1 hypersensitivity reactions. And anaphylactic shock is a spasm of smooth muscle cells of the respiratory tract, systemic vasodilation, low blood pressure, failure of organs, and then swelling. So they require epinephrine, not only to increase the blood pressure because you have massive vasodilation, but also because epinephrine opens up the airways so the person can breathe better. And that prevents death. Treatment for local is giving anti-leukotriene agents, corticosteroids, and allergen immunotherapy, in which you try to desensitize the person by injecting small amounts of antigens, little by little, monthly. And then as the person ages or receives this treatment, hopefully it desensitizes. Okay, someone is allergic to peanuts, the proteins in peanuts, and the person has anaphylactic shock first time. In the ER, they find out that it was peanuts, and they tell to the person, well, don't ingest peanuts or don't get in contact in an area where there are peanuts. Okay, the person obeys that, but the person wanted to see if the person would be able to eat peanuts again or not. What would you say? I'm not going to give you the answer.
Second time would be worse.
Second time will be worse. And then, do you think it would be a good idea to extract these proteins from the peanuts and start injecting tiny amounts in the person's skin to start desensitizing the person? Do you think it's a good idea? No. Chances are that the person is never going to get desensitized. I'd rather live without peanuts than die because of the peanuts. Okay? So allergen immunotherapy is possible for certain antigens, but not for everything. Okay? Especially if they already produce like a high hypersensitivity or a severe hypersensitivity reaction. Now for type 2, which is immune complex mediated or antibody mediated, basically you have IgM binding to the antigens from a blood type that is not your own. So that is responsible for agglutination or blood transfusion reactions when you have mismatch of ABO or RH groups that are mismatched. Type 3, which is immune complex. So you will have IgG binding to antigens and then migrating into smaller capillaries that get lodged into the capillary beds of kidneys or other organs, like the synovial membrane. And then you will have, type 2 was cytotoxic mediated. It's given with IgM. In this case, this is immune complex mediated, and it's for IgG. So IgG binds to these antigens, form a complex, migrates in the bloodstream, goes and clogs the small capillaries in the kidneys, or synovial membrane, or choroid plexus in the brain, and then you have the neutrophils going into that area and attacking these cells and causing an inflammatory reaction. Lastly, for type 4, just give me a chance, you have delayed. So in delayed, you have T cells, cytotoxic T cells, rather than antibodies and T helper cells recognizing antigens that are bound in MHC molecules. And then you recruit macrophages and sometimes cytotoxic T cells, and that will create an inflammatory response, for instance, in the skin, like poison ivy. It takes about 2 to 3 days, that's why it's delayed, to have this reaction. It can be a little bit more than that, but minimum 2 days. So this is all for this chapter. Any questions? Okay, so